Thank you very much. I wish just to stress, if you are looking for a balance between nations, I'm native of Luxembourg. I'm incidentally working in France. So I thank the organizers for the invitation and for, let us say, kind of a challenge, because the different situations I'm invited to discuss, to my sense, have only one common denominator. These are small numbers. That means there is no evidence, and it's perhaps a good opportunity to stress also the importance to make proper use of common sense and sound clinical judgment. So I have unfortunately no conflict of interest being surgeon. And to do a little bit of pre-lunch philosophy, I think the profession of the thoracic surgeon in the domain of oncology is moving, because there are mutations. We have improved diagnosis. We have more patient-friendly treatments, and this does not only apply to medications, but also to surgery, of course. The minimally invasive approach has replaced the thoracotomy in all-day surgery, and radiation therapy, unfortunately for our corporation, is moving. Then, of course, we are also facing the fact that lung cancer stays a fatal disease, and that staging is changing faster than overall prognosis. Sometimes when I listen to discussions, I come to the conclusion that if we cannot treat it, let us stage it. Sorry, I'm trying to move my slide further. There we go. So the first question is local recurrence, and I think this is a domain where finally we get back from the minimally invasive surgery to something which is more male in its aspect. And although there are no large series and every situation is quite different, so the only advice I can provide is that, well, we should have a very objective look at the situation and answer a couple of questions. First, is a complete resection anatomically feasible? Second, can the patient tolerate it on functional grounds? Third, is there an acceptable operative risk? And fourth, are there realistic chances for long-term survival? And then, of course, all this should happen in a multidisciplinary discussion, should be restricted to expert centers, because it's not only the surgeon who works, it's the whole team round. And of course, this is also the domain of multimodality treatment. I overlooked in this situation, of course, the small nodule in the peripheral part of the lung as a recurrent or new primary lung cancer. I was aiming at the more central relapses. So the second point is quite easy to clear, because there are very nice guidelines which have been edited by the British Thoracic Society, and I wish just shortly to comment on this. So the first slide here shows you that pulmonary nodules may be subclassified into solid and subsolid, and it's the subsolid category which will be focused now. And there again we have two different aspects. We have the pure ground glass opacities, which are not that frequent in our areas compared to the more eastern countries. And then we have the part solid nodule. We have a dense center and then some ground glass around it. So this is perhaps the most important slide of this section, because we need to know what is behind the radiological appearance before we can take any clear decision. And so you can distinguish a first situation with the atypical adenomatous hyperplasia, and this is usually pure ground glass opacity with less than 5 millimeters. Then you have the adenocarcinoma in situ, which is still considered to be premalignant. Again, a poor ground glass opacity, but the size can, of course, be a little bit larger. And then we have minimally invasive adenocarcinoma, which is an invasive part solid nodule with a solid area which is measuring less than 5 millimeters, and the invasive adenocarcinoma where the solid component is becoming larger and exceeds 5 millimeters. And there I wouldn't need any further slides because it makes sense that the last category here should be resected. The first category, well, it makes some sense just to watch and see what happens, and then to discuss the intermediate situations. But as I have still some time left, let's go to some other slides. Here are the different radiologic appearances. This is drawn from the British Thoracic Society paper. And then we have a diagnostic algorithm here. When we have such a nodule, if it is less than 5 millimeters, we watch. If the patient is unfit for any treatment, or if the opacity is stable for more than 5 years, this is certainly not for the surgeon. But then if we go to the other categories, the first question, as always in respiratory medicine, is if there's any previous imaging, and if there is no change, we can continue to watch for at least 5 years, no change before we stop. And if we have no previous imaging, then of course we have to check after a couple of months, because for instance, pure ground glass opacity and even these kind of semi-solid nodules may be of infectious origin and may completely disappear. I had a patient like this 2 weeks ago. When I sent him to transthoracic needle biopsy, the radiologist called me back and he said there's nothing more left to be punctured. So this is realistic. But then, of course, we come into the category when it is still there. When it has grown, then of course it's straightforward. And if it is stable, then we have to have, again, a closer look at the clinical situation. Is this a patient at risk for cancer or not? If it is a low risk, we can continue to watch. And if it is a high risk for malignancy, we have to do something, either straightforward surgery or some kind of biopsy or non-surgical treatments if the patient is not fit. So that's the substance. There is one detail in this paper, the Brock model, which should give us some indication if the patient is at high risk for lung cancer. And what is the Brock model? Well, it is a kind of algorithm taking together all these different parameters. The publication is here, and then you find online risk calculators where you have just to table in the different data from your patient, and you get the risk factor. The Brock model doesn't solve all problems, because look at this nice diagram. This here is the likelihood of cancer, and this is the size of the nodule, and here you have the different risk models. So you see that the Brock model is here, but the risk may be assessed differently if it is a smoker, non-smoker, and so on. So this is indicative. It is, of course, not histology. Then the PET CT scan in this debate is also of relatively pure contribution, because if something exceeds 2 centimeters, I would call it rather more a tumor than a nodule. And if it is less, you see that benign malignant on a positive PET is more or less 50-50. And then the holy grail with transthoracic needle aspiration. Unfortunately, in real life, it happens that we have non-contributive biopsies. And what is then? Well, then again, you see that here you have the pre-test probability of malignancy and the post-resection or whatever you do probability that it is a real malignancy. Then you see that clinical judgment is again the best, because the higher the assumed risk of malignancy, the more likely it is that we confirm. And we can also refer to former studies which have compared a transthoracic needle biopsy to educated guess by some experienced observer, and the difference is not that much. Then how should we go further for treatment? Then again, when the patient is not fit for surgery, we know that we have the possibility to do some stereotaxic irradiation or radiofrequency ablation, where my preference would definitely go to radiation. If we have no, if the patient is fit, we can just go in, wedge out if it is a peripheral location, and complete with lobectomy or segmentectomy if it is cancer. And if it is more central lesion, it's better to go for an imaging guided biopsy, and then again you see how all this splits up. Okay, this is very nice. And what we can take as final messages is that we should consider resection if it is a poor ground glass opacity of more than 5 millimeters, if there's progression, and last but not least, if there's change of the solid part. The diagnostic strategy, as we said, is either wedging out peripheral lesions with frozen section or transversic needle aspiration for central lesions, because if there's no high likelihood for cancer, it would be a shame to chop out the lobe for something which is not cancer. And then the debate about the value of segmentectomy has been set with this nice meta-analysis, which concludes that segmentectomy equals lobectomy in tumors less than 2 centimeters, T1A and 0, and in all others, lobectomy does better. Then, of course, what is not written in the meta-analysis, when is segmentectomy reasonable? It is definitely when the tumor is far away from the intersegmental space. So now the multiple primaries, that is an interesting topic which would deserve half an hour talk by itself. What we can say is that again, we have a little bit changing epidemiology as far as until recently lung cancer could most often heavy smokers. There was association with head and neck cancers and sometimes esophageal cancers. And these multiple primary lung cancers may happen at the same time or in a different time setting. And finally, in this debate, it is nice to have some old papers going back to the second, third of last century, which are still valid to discuss whether this is a recurrence or a second primary. So at least there is one instance which has no doubt, that's the TNM classification, which says that if the nodule is in the opposite lung, it is metastatic cancer, it is the M1A category. However, simple contralateral nodule, why should this be a metastasis? Could anyone explain how it can spread like this selectively from one lung to another? I don't see a hematogenous or lymphatic pathway or some seeding. And actually, if we discuss a little bit further, these two nodules may be different histologies. And then, of course, these are two primary tumors. And then if it is the same histology, this does not oppose to the fact that it might be two primary tumors. I would like now to introduce the concept of field cancerization, which is eloquent in smokers, where we know that there are diffuse abnormalities of bronchial mucosa with more or less pronounced dysplasia. And then, of course, we have also kind of new field cancerization in adenocarcinoma with the different mutations. What is the prevalence of these multiple primaries? It's very largely differently rated, and this depends on how you select the patients you bring into your paper. This doesn't add that much to the debate. It's perhaps better to see what happens after treatment. And this is a nice study which compares patients who got bilateral operation and those who got unilateral operation and some other kind of treatment for the opposite lung. And you see that surgery gave much more chances for long-term survival. And here again, if we compare surgery with a resection of both diseased parts of the lung is much better than just chemo. Operative mortality, there's no surprise. the range is quite large and definitely depends on type of surgery, and most authors say pneumonectomy is much more dangerous than lobectomy. I think this is not a surprise. If we go into a large series from our colleagues from Marseille, we see that 5-year survival in these patients is not so bad, 34%, that's at least an N1 cancer. And if these patients are N0, survival may be similar to stage 1 lung cancer. And if there are invaded lymph nodes, the survival is not worse than in stage 3A. So that's it. And pulling some studies together on the slide, we see that in bilateral lung cancer, which is N0, survival chances are quite fair. Now, the question if it is better to have the two tumors at the same time or in successive time, according to the work from our colleagues from Marseille, it seems that it would be even better if it falls together. If we compare to T3, T4 categories, we see that the M1A situation is no worse and quite often better than a lower category, which is quite paradoxical. Main prognostic factors, no surprise, is lymph node invasion, blood vessel invasion. The question about histology is more tedious because if the two nodules are of the same histology, for some authors it's better, for some it's worse, for some it's indifferent. So there's no way to conclude on this. We see that for this multiple primary squamous cell cancer has a slightly better survival than adenocarcinoma. And in the multivariate analysis, this is perhaps the most important slide of this setting, because this is what we need when we are facing a patient to decide. And here we see, and absolutely no surprise on this, that the risk factors for the prognosis are decreased lung function, requirement for pneumonectomy, if we cannot perform radical surgery on both sides, and if there is lymph node invasion. And this here again stresses out more or less the same, emphasizes on the N+ status as adverse risk factor. And then this is more statistical work. We see that patients who have no risk factors survive better than those who have. And for me, it's always very satisfactory when statistics confirm common sense. So what can we conclude? That resection is better when it is feasible. Of course, try to save parenchyma. Node dissection is still mandatory. If the patient is N+ and you know it before the decision, this is something to consider. There is no oncologic reason to deny resection, at least. And last but not least, please explore fitness, especially if you plan for bilateral surgery. The surgical approach, well, there's no reason to change what we are doing in all-day life. If that is possible, it's certainly preferable. So, last few comments on the oligometastatic cancer. Least we consider that what we discuss now is a variant of oligometastatic cancer. The true oligometastatic cancer is a relatively recent nosologic concept, considering that some cancers, for some unknown reasons, just pop out with a single metastasis, and the archetype for lung cancer, at least the first situation which has been fought by treatments, is the single brain metastasis. So what we can see from larger surveys is that the category of oligometastatic cancer nowadays is 8 times out of 10 adenocarcinoma. The median survival we can achieve with radical treatment on both the primary tumor and the metastasis is quite valuable. It's more or less double the survival as we observe for metastatic cancer, which is not operated. So let us do some comments on this situation with single brain metastases. Well, it is no surprise that brain metastasis, especially in adenocarcinoma, is a frequent metastatic site. And here you see what happens with the more classic treatments without any active intervention. So the rationale to do some curative treatment basis on the fact that the primary tumor is resectable and the patient fit for resection, that there is a single brain metastasis and there is no metastasis outside this area. The options we have to treat the brain metastasis is either surgery or stereotaxic radiation therapy, and here we have some papers from the literature going to 5-year survival rates, which may be averaged around 20%. This is of course not fantastic, but it is no worse than an N2 disease. And then when we operate the lung and just do some stereotaxic irradiation on the brain, well, here we have no 5-year survival rates, but the median is perhaps not the best in this series, but it's an option. So then there are different ways to discuss, and this comes up in MDTs. Should we do some total brain irradiation, whole brain irradiation after neurosurgery, or should this whole brain irradiation alone be enough? We see that the meta-analysis favors surgery. And if we oh no, this is not interesting. Let us move to this one here. No, it's an over-optimistic situation where patients with brain metastasis have the same outcome than patients without. So I don't see how we could do rules out of this. Here is a manuscript which analyzes and comes to the conclusions here that stereotaxic irradiation is better in combination with whole brain irradiation than whole brain irradiation alone. And if we add this whole brain irradiation, we decrease the risk for distant recurrence. However, we know that there are serious side effects with this whole brain irradiation, especially for people in our range of education, where it may become apparent. So this is something that has to be discussed. Then we can do quite similar comments on adrenal metastases. They are quite frequent at autopsy, but the single solitary adrenal metastasis is not that frequent. So there again, it makes sense to treat if we can do reliable resection for the primary tumor, and if the adrenal metastasis is single and resectable. So here are some series of taken from the literature where you have variable 5-year survival rates, but at least it seems worthwhile. And here we have another review addressing the question whether it is whether there is a difference if you have this metastasis in a synchronous or metachronous fashion. And there again, the results are, well, 5-year survival is more or less identical, but the median survival differs. So it's probably better to be in the metachronous group, at least for the disease-free interval. How to treat the adrenal metastases? While we are doing a big debate whether we should do an open surgery or laparoscopy, we should perhaps not fight between surgeons, but look to the radiation therapists who take also the lead with the stereotaxic irradiation in this category. So what can we say about the oligometastatic cancers as take-home message? Well, the first message is selection, the second is selection, and the third is selection, because all these patients are, of course, very well selected. As we said several times, the primary tumor should be resectable and of a low stage, and the metastasis should be single and resectable or irradiable. Favorable prognostic factors that appear are an increased disease-free interval of at least 1 year, adenocarcinoma, and of course, if we can treat these metastases radically. So the unanswered questions in this domain is up to how many metastases can be considered as oligometastatic. And this applies not only to the number of metastases, but also to the number of metastatic sites. I have absolutely no idea about it and would be happy if somebody knows. Then there's another situation we see quite regularly now at our MDTs. There is a patient with multiple metastases. He has well responded to tyrosine kinase inhibitors, but there is all of a sudden one nodule in the lung which is growing. What shall we do? Should we resect? Should we watch? And to come to some conclusions, the common denominator in all this debate, as I said, is sound clinical judgment. So, as always, we have to carefully assess operability. That means the anatomical extent of the tumor, the functional fitness of the patient. We have to carefully evaluate the risk-benefit ratio, which is the operative risk, which are the chances for long-term survival, and which is the quality of life we leave to the patient. And then the third point is that we have to be team players. We have become surgeons because we have a strong ego, but we have to confess that some colleagues also know something about it. And this is the added value for the patient to bring these files to multidisciplinary tumor discussion rounds, and of course to favor multimodality treatment when it is appropriate. So there's nothing to worry. There is still something left for the aggressive classic surgeon. I wish just to have some thoughts for my team, which is working while their boss is playing, and I thank you for your attention.